Thank you. That was great. I really enjoyed that. Our next speaker is Associate Professor Liz Hovey. Dr. Hovey is a medical oncologist at Prince of Wales Hospital. Liz has been around for many, many years. She was a big instigator for this support group, Education for Patients, this being Brain Tumour Action Month of May. We've held forums for patients in education, sessions like this for many years, which Liz has always been a massive driver for. So very, very thankful for you to be here today. Thank you.
I'm a Luddite, so what do I need to do? So what do I press? Just that.
Just there.
And the laser is which button?
Top is the laser. Is a fancy.
The top. Okay, great, thank you. Yeah, Marina's right. In fact, we've been running an annual brain tumour forum since 2004, and we only missed 1 year due to COVID. So it's been, the clinical community is very passionate about making sure that we interact with the neuro-oncology patients. And this is actually the first time that we've done a deep dive into this particular question. So I'd really like to thank Ray and Michael and Marina for asking me to come and talk. I only saw this heading after I'd written my speech, so it's a little bit broader, what I'm covering, sort of a little bit more holistic than just the chemotherapy. So I've sort of called this "What do we do when a tumour is on the move?" And the reason for that is recurrence is a strange word, really, or relapse is a difficult word in this scenario because, as has been alluded to by Michael and by Jonathon, there's always disease left behind. So it's not like a patient was completely clear of disease. Even with gross total resection, we know the nature of the astrocytes and their tentacles. There's unfortunately generally always something left behind. So it's not really a relapse from nothing, and perhaps progression is a better word than recurrence. The one good thing is that unlike other cancers which can sort of go anywhere, usually these diseases stay in the brain. Very, very rarely it might go down the spine. And I've seen it like 3 times in the 20-something years I've been doing it, but including this week. One. So because of the short nature of this talk, I'm really going to concentrate on high-grade tumours. So we've seen already examples of the actual tumour. This is what it looks like under the microscope with some specific features. This is a classic appearance of a glioblastoma, and this is a classic appearance of sort of a multifocal high-grade glioma. And in particular, I'm going to be talking about glioblastoma, but regardless of what tumour people in the audience are thinking about, the concepts of how we approach relapse or progression really are very similar. So what can we see? Where is it? We've been talking, Jonathon talked about important bits of the brain where if you cut that out, the results can be devastating. That's sort of called eloquent brain. So we know that those bits of the brain do something very important, whether it's speech or moving the arms or the legs. And how deep is the tumour? How accessible is it? Is it inside the prior radiation field? Is it on the lining of the brain, which is called leptomeningeal? Is it one nodule? Is it multifocal? And also, has been alluded to, when has this progression occurred? Soon after radiation? Is it definite, or is it going to be pseudo-progression, which is those treatment-related changes that Michael talked to us about? Has the tumour got worse while on treatment? So you're taking your 5 days of temozolomide, 5 days on, 23 days off, and the tumour's looking worse, and it's more than 6 months post-radiation. Is that when it's happened? Or has the relapse happened during a treatment break? And if so, how long ago did treatment stop? And also the molecular factors. What do we know about the tumour so far? So a lot of you out there might have heard about MGMT. So MGMT is a repair enzyme. It gives the tumour an advantage because the tumour can just keep repairing itself. But if the MGMT is silenced or what we call methylated, that gives the the clinicians and the radiation and the chemotherapy an advantage. And how has this presented? Is the patient symptomatic and so you've called them in for an early scan, or is it asymptomatic and an unexpected finding when you've done a routine scan? And all of those factors sort of come into our decision making about what we're going to do and whether we're going to press the change treatment button. So we each have our role, and I think that we're echoing each other because it is so true. We none of us are sole soldiers. We all rely very heavily on each other. It often is the GP or the neurologist who brings patients to our attention. The neurologist might come back in later if there's management of seizures that's a challenge. The neurosurgeon obviously is that all-important person who's going to debulk, give us the diagnosis, and very important in that upfront and if appropriate at relapse as well. The neuropathologist is incredibly vital to give us the nuances of what kind of a tumour this is and whether or not some newer targeted agents might be applicable if there's particular mutations. A radiation oncologist like Michael, a medical oncologist like myself or Helen Wheeler or Adrian, the cancer care coordinator like Marina, palliative care clinicians who play a very important role, and we're going to hear more this afternoon from Bridget. Allied health, physiotherapy, occupational therapists, other specialists, rehab, endocrine if you've got steroid-induced diabetes, dermatology if you've got nasty rashes, social workers, speech pathologists if you've got problems with your speech or with swallowing. So there's a whole lot of people involved with the patient journey, and we all recognise that the team is vital. And perhaps there's different leaders at different parts of the patient journey, but we're all passionately interested in what is happening to our individual patients. We've had a great session about the MRI and the different aspects of the different phases, and it's all those different aspects to the MRI which help us decide whether this is a treatment effect or a true relapse. There's something called spectroscopy, which I'll show you another picture of in a second, which can sometimes help, but it's probably been debunked. Not every centre is lucky enough to use PET-FETs, and I'm fascinated to hear about the dynamic FET-PET. I'll try and learn more about them, see if we can bring them to our shop. So this is a spectroscopy of a normal sort of neuronal tissue with an NAA peak and choline creatine peaks, and then if it's a tumour, you'll have inversion of the choline creatine. The NAA will be suppressed, the lactate might be up, so that will give you a clue that that's tumour rather than treatment effect. So as we've already heard, it's not just the MRI. In fact, Helen Wheeler, when I first started doing brain tumours in 2001, said treat the patient, not the scan. And it's really important that concept of performance status. So I'll just run through ECOG very quickly. ECOG 0, no symptoms, you're doing everything you normally would do. ECOG 1, some symptoms, but you're still functioning really, really well. ECOG 2, lots of symptoms, but you're out and about, you're out of bed more than half the day, you're still doing some things for yourself. ECOG 3 is where it starts getting tricky, more than half the day in bed, and dependent for some things, but still doing some things for yourself. And ECOG 4 is when you're really dependent and bedbound. And we know that if you're ECOG 3 or 4, it doesn't matter what tumour it is, the chances of chemotherapy helping are very, very low. You're probably more likely to the chemotherapy is probably more likely to be associated with harm rather than benefit. So we look at ECOG, we look at the current quality of life, we look at patients' activities of daily living. Are they looking after themselves, bathing, toileting, feeding themselves? And there's also something called IADLs, instrumental ADLs. So apart from the really basic needs like bathing and clothing, are you doing your bills? Are you making your phone calls? Are you doing your shopping? Are you preparing your meals? Those kinds of things. So all of that's really important to get a sense of where the patient's at. What are their supports? A socially isolated patient, you sometimes do make slightly different decisions if they're really all alone. And every patient's unique in terms of what their priority is. Some patients, they want to be treated to the last minute. They want to turn over every stone. They want to fly the world for clinical trials. Other people might say, you know what, I've actually had enough of treatment. I want to focus on family and travel. Maybe let's stop active treatment. Let's focus on best supportive care and symptomatic management. And that's very individual and it can shift as the journey goes in terms of what people's priorities are. So it's really important to listen to what the patient's goals are when you're making sort of decisions about what to do next. So as we've said, the first thing we need to do is, are we sure, is it a progression? If no, the importance of sequential MRIs, as Michael said, perhaps re-scan in a month or two. If we do think it is progression, we need to decide on what we're going to do first. And if there's more than one treatment, what's the sequence? Is surgery feasible and safe, which Jonathon's just dealt with? And often this is favoured if possible because it's nice and quick. You get the minimisation of the pressure, you get more tissue, but there's only certain tumours that are appropriate for that if it's not an eloquent brain, so you're not going to have a devastating consequence, if you're quite fit, if it's not multifocal, because if it's all over the brain, or if the surgeon's going to get, say, less than 70% of the tumour, that's not the route to go down. How long ago was radiation? The longer the better. Like, it used to be that reirradiation was barely ever offered, but if it's in a new spot, like completely the opposite side of the brain, like I think we saw some pictures there with Michael, you can sometimes even redo that upfront STUP protocol, which Bob Smee at my shop and I have sometimes done with patients. We do the whole STUP protocol again with radiation and temozolomide if it's not in an area that was in the previous radiation field. So does the lesional area overlap with the prior radiation field? Can the area be radiated or re-irradiated, which Michael will talk about more? And also, if you do re-irradiate, do you do it with or without temozolomide to help the radiation work, particularly if the tumour looks as though it's got worse on the temozolomide? So all these questions. So we've talked a bit, Michael's covered pseudoprogression very well, which is those treatment-related changes that happen in the first within the first 3, sometimes even 6 months post-radiation. And sometimes we just have to sit tight, keep treating with the temozolomide, and you'll be rewarded with the resolution of that area. So if the progression occurred while the patient's on temozolomide, it's generally time for something new. If it occurred while on a treatment break, we often recommence temozolomide. And you might go right back to that 5-day schedule they were on before. And you'll be more confident about doing that if there's been a decent break, so some months rather than just a month or two. The drug we most often reach for is lomustine. In this second-line setting. It's an oral tablet. It's like temozolomide. It's an atypical alkylating agent. The other name for it is CCNU. So some of you in the room I know have had PCV, which is procarbazine, CCNU, or lomustine and vincristine. So that's where the C comes from. The other drug that is very important in the recurrent setting is Bevacizumab. It's a monoclonal antibody against something called VEGF, the vascular endothelial growth factor. It's given intravenously. Some of you might have heard about it with the word Avastin, because that was the first brand name for that. And there's also some interest in combining the two. There was a phase 2 study in Europe which showed really nice response rates with the combination. The phase 3 results weren't striking enough in terms of survival benefit to sort of say, look, it's definitely worth combining it, but many of us do still combine it. And also clinical trial if available. Hao-Wen's going to be talking later today about novel treatments, and I'm sure he's going to talk to you about clinical trials. So, lomustine. So at the beginning at the turn of the century, it wasn't used very much. It had kind of fallen out of favour because of the new kid on the block, temozolomide. And then there were all these new drugs being developed, and there were these large, expensive clinical randomised trials, and the drug companies all sort of leapt upon lomustine to use as the control arm because I think they were pretty confident it wouldn't perform that well. And there was drugs called enzastaurin, selengitide, cediranib. But interestingly, and I guess disappointingly in terms of the new drugs, lomustine outperformed the new drugs in each study. So it became popular again, and it's still internationally the gold standard for relapse. We give it every 6 weeks. Side effects include nausea and vomiting, so we give with antiemetics, so anti-nausea drugs. It can cause myelosuppression, so that's low blood counts, particularly the platelets, which stop us from bleeding, and the neutrophils, which protect us from infections. And sometimes that drop in blood count doesn't happen immediately, can happen some weeks after the fact, which might mean you can't give the next lomustine at the 6-week mark because the counts are low. So you might need to dose reduce. Occasionally it can cause abnormal liver function tests and fatigue. There is a little bit of politics about the ongoing supply of lomustine. Unfortunately, BMS has sold the rights in America to another company who've been price gouging. I think it's gone from $7 a tablet to $1,500 a tablet. So luckily that has not happened yet in Australia nor in Europe. But BMS are going to stop supplying here. It was meant to be last December. We've pushed them out to December this year. But there's a number of us currently in negotiation to safeguard the supply of lomustine in Australia. So watch this space, and BTAA is possibly going to play a very important role in advocacy. And if we have to play dirty and go to the media, so we will. So in terms of bevacizumab, we know that just like when a new suburb is built, you need new roads. When a tumour grows, you need new vessels. So angiogenesis is essential for sustained tumour growth, and that's the whole hypothesis of why if you can have an antibody against the vessel growth, the Avastin may in fact help. And it seems to normalise the vasculature. So the first picture there is of normal vasculature. That's the abnormal vasculature of a brain tumour. And Avastin seems to lead towards more normalisation and disappearance of some of these new little vessels that the brain tumour sprouts. Interestingly, not only does it help with the vessels, it really helps with minimising edema or swelling around the tumour. So it's a monoclonal antibody. That's kind of what it looks like. It's what we call a humanised antibody with a little bit of mouse, 7% murine, and it recognises and neutralises that vascular endothelial growth factor. It wasn't used in the brain tumour setting for a long time. There was a great fear that it would cause bleeding because of the nature of what it did, until a plucky female oncologist in America called Stark Vance tried it on 21 patients, and it really improved. There was a response in 44% of the patients. So we all sat up and took notice, and it became very mainstream. It can even, once you give it, it can sometimes look miraculous. Someone who couldn't lift their arm one day is lifting their arm the next. Someone who wasn't fluent in their speech can speak in fluent sentences once the Avastin's on board. Sometimes these benefits are long-lasting. Sometimes the benefits are short-lasting and temporary. But the swelling really improves. So there was great hopes initially that it would improve survival. There were some big randomised studies which Australia participated in, and it showed improvement in function, maintenance of independence, but sadly it didn't statistically show improvement in overall survival. But I have absolutely no doubt that some individual patients do benefit greatly from it. And the other big advantage is, instead of being dependent on dexamethasone, which as we know has a lot of side effects like insomnia and diabetes and fluid retention and emotional lability, it means if you get rid of the swelling, there's much less steroid that you need. So that's a huge advantage in itself. We need to be wary about something called, instead of pseudo-progression, pseudo-response. Because the leaky vessels aren't there, there's less leakage of contrast into the film. So sometimes the films look a bit better than they actually are. We're learning not to necessarily give bevacizumab right up front. Keep it in your drawer till you really need it. But certainly if there's edema and a lot of steroid use, we often reach for it. It's given intravenously. It's weight-based dosing every 2 or 3 weeks, 10 milligrams per kilogram or 15 milligrams per kilogram, but probably lower doses are fine. I know that the guru Roger Stupp uses a very low dose. Side effects, if you've had lots of brain tumour surgery, sometimes the wound can break down and you can get leakage of the spinal fluid. It's rare, but it's important. So we've got to be very careful not to introduce it if more surgery is planned or if someone's just had surgery. High blood pressure, protein in the urine, rarely something called nephrotic syndrome, possibly increased vulnerability to infections, low white cell count, a very slightly increased risk of strokes or clots and brain bleeds, but it's small and acceptable, and occasionally arterial events, and less commonly diarrhea, constipation, nausea, vomiting, loss of appetite, but that's not very common. Most people really tolerate it very well. Bowel perforation happens in 1% of patients. So if someone's got a sudden acute abdomen, we need to be aware of that. Nosebleeds. And one other thing I didn't put there on the slide is it seems to do something to the vocal cords. So often patients have a husky voice while they're on the Bevacizumab. So this is just a picture of the pseudo response. If you look up the top, A, and then when you start the Avastin, all the contrast enhancing disappears, but the non-contrast enhancing in B actually gets bigger. So sometimes you get discordant. Some part of the tumour looks better, some part of the tumour looks worse. And I'll, just for interest of time, this is like an example of a patient, December, that was their flare picture. And then after the Avastin, you can see the great improvement. This was the contrast picture in a December, and then subsequently in the February. So we have to be a bit wary of pseudo-response as well. So what's next? What do we do? Third line, clinical trials if they're available. Some of us give different schedules of temozolomide to give the tumour less of a chance to recover. So we might give what's called metronomic, so it's low dose, but we give it, for example, 3 weeks on, 1 week off instead of the 5 days on, 23 days off. And some of us might throw other drugs in with a temozolomide, like something called procarbazine. But none of those approaches have been proven to be superior or standard. We've stopped using a number of drugs. So carboplatin, we did an Australian study comparing carboplatin plus bevacizumab versus bevacizumab, and we showed, sadly, that the carboplatin didn't add anything to the mix. Hao-Wen from Melbourne was very involved with a drug called ABT414, an antibody drug conjugate, which it attacks the amplified epidermal growth factor receptor. There were lots of anecdotal results in the early studies, and we were really hopeful, but the phase 3 study was negative. And also many years ago, we were involved with a big EGFR vaccine study, which sadly was negative. But there are still lots of drugs around the corner that we're working through. Carmustine wafers at the time of surgery looks, which is again an old thing, looks useful but is tricky and can cause wound healing problems. And the way they ended up approving it was not helpful, because it made you choose between temozolomide or the carmustine wafers, and also it was put on the PBS, and you can't use PBS drugs in a public hospital. So very vexed. Overseas, so is there something you can get overseas that you can't get here? There's something called Novo TTF, tumour treating fields, which sort of flip-flop the electric fields and act upon rapidly dividing cells. It's incredibly expensive, $30,000 American, I think, per month. It's not available here. We're too small a market. It does cause scalp irritation, headache, sometimes nausea, lethargy, and you literally have to shave your head and stick it onto your head and wear a backpack 22 hours out of 24, and the average benefit's just a couple of months. So, even though it's sad that option's not there, I don't think any of us really think that we need to sort of barrack too hard for it, because it's probably not financially worth it. It doesn't really provide that bang for your buck. There's other things around the corner. I just saw actually last night that a drug had been approved called azilurigon, which was in America, which was an Alzheimer's drug, which looks like it might be interesting, but the definitive studies have not been done. And I've also heard that the IDH inhibitors for lower grade gliomas, the results are looking very interesting. So other aspects of care, I'm coming to the end. it's not just about the tumour, it's about everything else that's going on with the patient: mobility, vision, memory, insight, speech, seizure management, headaches, fatigue, mood, personality, complications like clots, which are very common with gliomas, and vulnerability to infection. So we've got to always keep an eye on all of that. Patients are often on a lot of drugs. That can be exhausting. Steroids, as I've mentioned, can cause emotional lability, reverse sleep-wake cycle, cause insomnia, high sugars, weak muscles, so the thighs and the top of the arms can get weak, anticonvulsants, anticoagulants, antiemetics, antibiotics, stool softeners, and medications for other conditions. And if patients are struggling with their memory and they're living alone, that can also be an issue. I've had patients where the neighbours have had to give the drugs. We really recognise the importance of the carer and the importance and the need for the system to care for the carer, because it's the carers for brain tumour patients have to do a lot, and there is a risk of burnout. Sometimes people need to give up their job, go part-time. The patient might have been the person with the income source. There might be young families. There's frequent clinic visits and the patient no longer drives. There's hiring equipment, home modification, financial issues, needing to access superannuation, carers allowance, disability allowance, NDIS, insurance reports. There's a lot of admin and it's exhausting, and we recognise that. And this is back from 2007, and the average out-of-pocket cost, or sort of cost per patient, $47,000 out-of-pocket for the family and for the system, average. But the brain tumour per patient, including the health costs, the other financial and employment loss, it was averaging back in 2007 $150,000. So this is a really needy group. So my final thoughts are, it's really important for patients and carers to focus on goals and priorities. I want to reassure you that there's lots of ongoing research, many of which looks exciting, and Hao-Wen will tell us more about that. Many patients continue to function well, live well, travel, write books, give sermons, give speeches. I had a patient the other day who gave this, international economic talk, despite her tumour progressing. It's very important to assemble your team, your medical team, your personal team, utilise what's available, and accept help from your family, friends and neighbours where offered, because the carers need to have support and rest. If you've got any questions, I'll be on the panel. Thanks for your time.